So the objectives are to talk through two clinical cases. I'll try and be brief, and then the learning from these cases. And I will very briefly talk about CPAP, but I'm not going to go into the settings, as I know there's an intensivist also speaking. So a couple of COVID cases that we saw early on during the experience. So the first case is a 65-year-old gentleman who had a long history, probably more than 4 weeks, of a dry cough, and was diagnosed with asthma a month prior to coming into hospital. Before his presentation, he had had 3 days of fever and breathlessness, the more classic symptoms of COVID. So we took that as the day one of symptoms, 3 days prior to admission. He had had a negative COVID test prior to coming in, and he was independent, lived with his wife, worked at Heathrow Airport as a baggage handler, but did not do any regular exercise. So his Rockwood Frailty scale was 2. I don't know if you're familiar with this scale, but this is a slide of the scale that we commonly use in our hospital for determining how fit somebody is. And there are some special inclusion criteria for people with dementia. So he was doing well on the scale 2 with no active disease symptoms, but not fit as in doing regular exercise. So when he presented, he did have a temperature, and he appeared to be in respiratory distress with a high respiratory rate and high heart rate. His oxygen saturations were significantly reduced on air, but came up on 4 litres of nasal cannula oxygen, and his respiratory rate improved to 24 with oxygen. On auscultating his chest, it was clear without wheeze on admission. And his results came back as positive for COVID PCR, with white cells that were normal. There was a mild lymphopenia, and his D-dimer was high on admission, with high inflammatory markers, including C-reactive protein, ferritin, and LDH, which we are commonly testing routinely for our COVID patients. So this was his chest X-ray on admission, which, as you can see, shows bilateral extensive infiltrates, despite not having any clinical signs on auscultation. And we felt that this was his day 3 of his COVID infection course. So because of his high D-dimers and inflammatory markers, and because we know of the risk of thromboembolic disease, he went on to have a CT pulmonary angiogram, which didn't show any pulmonary embolus, but did show extensive infiltrates with mid to upper zone predominance. And there's also traction bronchiectasis here, suggesting some element of more permanent fibrotic change. So the question was raised as to whether he had any underlying lung disease, despite not having a history of such. So he was treated with prednisolone because of his background of asthma, antibiotics. His respiratory rate remained high despite the oxygen, and his oxygen requirement slowly improved. However, his fever persisted to day 10, despite improvement of his C-reactive protein, and he deteriorated on day 10, requiring more oxygen, and was sent to intensive care. And he was intubated and ventilated for 7 days, but did not require any other ITU support, such as vasopressors or filtration. So he came back to the ward on day 18, and he suffered a number of post-ITU complications, including keratitis in the eyes, critical care neuropathy and delirium, and pressure sores on the buttocks. He hadn't had his bowels open for several days and had an ileus, thought to be due to electrolyte disturbance. And at that time, the decision was made that he was in fact too frail to be considered for re-escalation to the intensive care department because of his deterioration in overall health status. During his ITU stay, he had rising D-dimers above, in fact, 20,000. That's a typo there. So he went on to have a further CT scan, which showed pulmonary emboli, which had happened over the course of his intensive care stay, and a large iliac vein thrombosis, which was treated with anticoagulation. And this was his CT scan on day 18 of admission. So you can see there has been some evolution of the CT changes and less dense consolidation, but there remains significant abnormality throughout the chest. So this gentleman was discharged to a rehabilitation care setting on day 39 of his illness. And he had significant morbidity relating to his ITU stay, including poor mobility, an infected pressure ulcer, and ongoing worsening breathlessness, and a urinary tract infection which was treated. So he is still undergoing rehabilitation at this time, and his family have complained to the hospital because they're unhappy with the outcome. I'm just thinking about the case series that was published in the Lancet by Zhou et al. They looked at about 190 odd patients and their clinical course, and we can see in the survivors that their initial symptoms were cough and fever, and they didn't develop the dyspnea until day 7. And on average, their patients were discharged a little earlier than this gentleman at day 22. In the patients that didn't survive in their paper, they tended to have an earlier deterioration at day 12 and develop sepsis a little later at day 10, which this gentleman experienced. So I think it's worth thinking hard about the patients that we select for intensive care, and I think that has been a real learning curve during the COVID period in the UK. So I'm going to go through a second case. So this is a 74-year-old female who had a history of 5 days of diarrhea and vomiting, and 3 days of fever with dry cough. We took that as her first day of symptoms, 3 days prior to admission. And on admission, she was very breathless with increased work of breathing and oxygen saturations of 88% on high flow oxygen on a non-rebreathe bag with a respiratory rate of 34. She had significant comorbidities, including type 2 diabetes, previous lymphoma, and a previous right lung lobectomy. She was on amlodipine, ramipril, and atorvastatin. And although she was fit, she cared for her sick husband at home. But in terms of the Rockwood Frailty score, she scored a 3. So she didn't do any significant exercise. She'd never smoked and had no previous other respiratory conditions. So this lady tested positive for COVID. And just looking at her admission blood tests, her white cells were normal on admission. She had a mild lymphopenia again, and a significantly raised D-dimer. Her inflammatory response was not as marked as the previous gentleman, but nevertheless was increased. So this was this lady's admission chest X-ray, which again shows typical changes of COVID-19 with bilateral pulmonary infiltrates widespread. And this was the CTPA she had, so there was no pulmonary embolus demonstrated on the CTPA, but there were extensive ground glass changes with also this crazy paving pattern with interlobular septal thickening, which is commonly seen, and there's evidence of previous surgery and volume loss on the right side due to previous lobectomy, and I suspect the scarring is long-term relating to that. And there's another slice, so this is throughout the lung fields. So this lady came in, and on admission, we decided early on in the admission that thinking about escalation, she should not be for cardiopulmonary resuscitation in view of her comorbidities and her frailty score, despite the fact that she was fairly independent. It was decided that this lady would not benefit from intensive care treatment. And on reflection, thinking about the effect of COVID on different age groups, it was felt that she additionally wouldn't be a candidate for non-invasive ventilation on the basis of the constellation of age, comorbidities, and frailty score. So it was decided that this lady would have a ward-based ceiling of care. And this is some data from late March based on figures from Italy and China, which shows the percentage of deaths in the lower bar here in the different age groups, and the cases requiring hospitalisation in percentage based on the different age groups. Whether that was the right decision or not, I'm still undecided. But the clinical course, so she had bacterial infection treated, and her respiratory distress slowly improved whilst on the ward. She was alert and feeling better in herself. Her oxygen saturations remained very low, despite the 15 litres of high flow oxygen. And it was decided that she was very unlikely to survive this episode, and there was a compassionate care agreement decided, which means that we were going to focus on her care, expecting her to deteriorate and eventually pass away. We would support her in this process. And this was her repeat chest x-ray. Despite the fact she was feeling better, there were more extensive changes on the chest x-ray supporting progression and worsening of her condition. So on day 18 of her illness, she was discharged to a hospice on high flow oxygen and expected to pass away in the coming days. However, she actually gradually improved during her 4-week stay in the hospice, and surprisingly was able to gradually wean off the oxygen, and was in fact discharged home after a number of weeks in the hospice. So she's actually doing very well, I understand, at the moment, and this was a lady who was not expected to survive, and a lady that we didn't offer any sort of respiratory support beyond oxygen or intensive care treatment. The fact that she's female obviously went in her favour, and she actually has done very well, which I think the learning from this case, I think we have to be very careful about the treatments that we select for patients, particularly when we need to be mindful of resources. This has been a huge concern in the UK. So just moving on to talking about ward-based respiratory support. I'm not going to go into any detail because I know Marcella is going to be talking about her view from the intensive care perspective. But these are just some pictures of our wards of people in their full aerosol generating procedure PPE, with the visors, the face masks and the gloves and full length aprons. So thinking about respiratory support for our patients, I think one of the most important things has been ensuring that the patient escalation decisions are made very early on when we meet the patients, and taking into account the frailty of the patients and the comorbidities as well as age. We were very concerned in our hospital at the beginning of the COVID crisis about running out of oxygen. And in the interests of conserving oxygen, I would recommend starting on low flow nasal cannulae and then using the Venturi at 35% as the escalation in order to conserve the hospital's oxygen supply. And then the non-rebreathe mask can be used if patients are still desaturating. And then for patients that are considered suitable for escalation of care, for example, to non-invasive ventilation, and by that, we have only been using CPAP. So we've not been using high flow nasal oxygen, and only seldom have used the bi-level BiPAP support. So in patients that are requiring more than 40% FiO2, or who have obvious increased work of breathing despite having a lower FiO2, I would advocate starting the CPAP therapy early. And I think we treated about 40 patients in our hospital with CPAP on the ward, and 18 of them have survived, and including 9 of the patients that were for full escalation, 8 of them avoided intensive care, and 1 of those patients went to intensive care and unfortunately died. So I think, although it's anecdotal, I would support early use of CPAP as an intubation avoidance strategy for patients that are for full escalation. And I've just put a link here for our government recommendations on personal protective equipment for aerosol generating procedures and general for care of patients with COVID-19.
Thank you, Veronica. Can I interrupt? Is that okay?
Yes.
So I think that, really feel very uncomfortable about the triage system.
Yes.
Because basically, where no foundations is true in the UK and around the globe, people
Yes.
follow what the Chinese team or group were presenting at the very beginning when they said that age, multi-organ failure, and high
Yes.
Alzheimer condition
Yes.
were the factors that will contribute to mortality. So
Yes.
a lot of people, not only in the UK, but around the world, started triaging. Say if you are a bit old or you got comorbidities, you will not benefit from hospital admission or admission to intensive care. So there were some guidelines that were put here and there. Probably all of you or some of you know the VIP study. That was one of the major clinical studies in Europe looking at old people, admission of old people into intensive care, so people more than 80, and benefit of these people of coming into intensive care. And clearly, it's not about age to start with, and secondly, it's not about comorbidities either. It's about the physiological response of the individual to a medical condition. So from the very beginning, and actually I was very vocal about this situation, not at local level, but at national level, and I've been in contact with Chris Whitty and with the team that were running with the president of Intensive Care Society. I wrote a letter that actually I shared now with all of you, where
Yes.
I did analysis of the mortality that was presented at national level in intensive care, and I actually did the analysis, dissected the VIP study, where clearly I showed that we must not triage. That was the wrong things to do, because the people that died were not people that were old, were people that were badly affected by the disease. And who were the people that were badly affected by the disease were normally male patients. And that, again, that is not something that was new to us, something that came from all the documentation from China, then the documents from Italy showed exactly the same, great preponderance of men. And
Yes.
that's one of the very, 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 very first things that we have seen as well. So I started looking into that. So I will expand later. So
Okay.
about triage is not something that was not our adoption. Person was Mr. Foundation Trust, was some early trends about trying to limit the level of care, but was not our view. We actually reversed and we opposed actually to the triage system. Unfortunately, few patients at the very beginning seems like were affected by this, and proved that we were right at saying we must treat people that are 80 plus, doesn't matter age, because actually, if you are a lady, regardless of your age, you become unwell, you can get through the process. The problem, but I can expand into all of that. I'm sorry, but I have to say this because triage is a bad word and people must not triage, need to have patients individually and manage as they are, because they proved all the publications that triaging was the wrong things to do.
Yes, and I completely agree with you. Be treating each patient as an individual.
Correct.
And I certainly don't support using any of the more directive criteria. But of course, we have to take frailty, for example, into account. Absolutely. Thank you.
Okay. Yeah.
I agree with you. And I did see your email. Thank you. I'm not going to go into this because I know you probably are, Marcella. But this is the CPAP that we were using on our wards. We have also purchased these kits, which are single patient use disposable kits, because we were worried we would run out of CPAP machines, and these plug directly into the oxygen supply. However, they do use a lot of oxygen, up to 140 litres. And we were starting our patients on a PEEP of 5 to 10 centimetres, up titrating in some cases up to 15, although I know there have been some problems experienced with pneumomediastinum on ITU subsequent to this. And just to note that this is an aerosol generating procedure, so it's important to ensure that at the bare minimum, these patients are cared for inside rooms with the appropriate PPE. And anecdotally, we have seen our patients benefit from regular proning, so 2 hours twice a day, for example. This has had a significant impact on these patients that have survived. So I'm going to leave it at that. Any questions at all?
So thank you, Veronica. If I may just jump in and just ask one question.
Of course.
So thank you very much for the talk. Actually, I had lots of questions in my mind, but you answered them as you were going through your presentation. So are you currently now doing, are you classifying your patient or doing any advanced decision whether they're going to go to ICU on admission? Do you make that directly?
Certainly not with any sort of scoring criteria. No, this is on a personal basis, and personal views should also be taken into account. So patients' preference is also very important here, as well as the family's opinion. But it certainly is a case-by-case decision, and I'm certainly not advocating any of these scoring systems.
Okay. But are you meant to make that decision like early on in the management of the patient?
Yes, in order to, so that we can understand expectations. I think it's important to clarify that with the patient and their family early on in their admission, so that we are all working on the same page. And I think that decisions in respect to COVID infection as opposed to other conditions, escalation decisions have been very different. As we know that patients do badly in general if they have COVID infection compared to non-COVID infection.
Thank you very much.
Thank you.
Thank you, Dr. Veronica. I had one question for you, is that in the first case, the patient had very striking changes on the chest x-ray. And my question really is regarding use of CTPA. In some centers, if they have if they have chest x-ray findings which are consistent with COVID, they don't routinely perform CTPA. What's your sort of practice?
So we know that they get high D dimers with COVID, of course, and we know they're going to be hypoxic. I think that a strategy, although there's no evidence behind it, has been to do serial D dimer monitoring, for example, after a 48-hour period to see if that has changed. And if the D dimer appears to be going up, in some cases we have gone on to do a CTPA. But oftentimes they will develop the pulmonary embolus during the admission, either to ITU or to hospital.
I will pick up on that when I go through the traffic light system that we developed for our trust. So it was a lot of background work in the background to identify that as well, and guide us in the management.
Great. Okay. Any other questions? Well, thank you very much, Dr. Veronica Smith. That was a fantastic presentation.
Thank you.